Easy peasy. All right, everyone, let's get started. This is kind of a long lecture, which is why I took Katerina that I couldn't break it up. But today, basically, I'm going to talk to you about lung and pleural ultrasound. Let me share the screen with you. 1 second. Okay, share screen 2. Excellent. All right, if there are any issues, just let me know. Perfect. Okay, so lung and pleural ultrasound. So today we're going to talk about the basics of doing a lung and a pleural ultrasound, how to perform it, what are the key findings that you find for each. I'm going to dive a little bit into also a very quick DVT ultrasound, because I think it goes hand in hand when we talk about lung ultrasounds. And then some applications and limitations, and also some real world current events that are happening and how to apply that, and then a few questions at the end, and time for review. So I'm going to just start off with some very basic stuff. A lot of you may already know this, but I think it's really important that we differentiate all the different types of probes. Just very quickly, probe number 1 is our straight linear probe. It's also our vascular probe. So these are our high frequency probes. They tend to lack penetration, but because of their high frequency, they tend to have much better resolution. And so they're really great for lung ultrasound, but not great, as we can see, for say cardiac or pleural ultrasound, or looking at the tissue within the abdomen. Our second probe is our phased array probe, also known as our cardiac probe. Most images actually that you do on the lung ultrasound, you can actually just do with this one. Its frequency is usually in the 3 to 5 range, so it's low frequency. So that low frequency means that it can penetrate deeper structures, which is why we use it for cardiac imaging and even sometimes abdominal imaging. But we can use this for both lung and pleural ultrasound, although the resolution may not be as great for lung ultrasound. And then, of course, our third ultrasound probe over there is just our abdominal probe, also known as our curvilinear probe. Again, low frequency, great penetration. It's great for abdominal and pelvic ultrasound, which is why I think we as anesthesiologists don't tend to use it that much, I guess, unless we had a really obese patient and we're doing a block for them. The biggest difference for us is that the footprint is much larger. So you just compare it with the phased array probe, you can see that it just sort of captures a lot more within the image, which may or may not be desirable, depending on what you're trying to see. Very quickly on the anatomy, just a very, very quick refresher. The right lung, 3 lobes, left lung, 2 lobes. Just a reminder that the right middle lobe is wedge-shaped and it opens up anteriorly. And so when you're lung ultrasounding, it's good to keep this in mind, because where you place a probe is what lobe you're going to get. So if I wanted to image the right middle lobe, I would probably image from maybe the side and the front, but probably not from the back, because I'm not going to get a very good image of it. Versus if I want to do the right middle lobe, I'm probably not going to image from the front of the patient, but probably from the side or from the back. Same thing with the lingula, and then the 2 lobes on the left side. Oops. Okay, so some very basic principles. The lung ultrasound offers a non-invasive and a readily available diagnostic tool at bedside. It gives you immediate results, which is really great. There's no time delay. It acts as an extension of your physical exam. So you can observe, you can palpate, you can percuss, you can auscultate, and then you can do your lung ultrasound and see if you can confirm your findings. And the really nice thing about it is that it is done at bedside, and it's done real time. The major limiting factor of lung ultrasound tends to be that the lungs are filled with air. The problem with air is that there's a large acoustic impedance difference between the velocity of ultrasound between tissue and the velocity of ultrasound between the air. And so this actually leads to a lot of reflection of ultrasound, scattering, especially at the air-tissue interface. Excuse me. And so that's why when you look at a normal lung, you'll see this homogeneous amorphic grayness that's actually seen deep to that air tissue interface. And this all looks like static, but this is actually normal lung. And this is an image that you have to get used to, because when you look at abnormal, you're going to look for something that's not this. The other issue too is that with lung ultrasound, it's very hard to see because of that, because air tends to scatter and reflect ultrasound waves, you most likely will not be able to see any sort of abnormality that's deep to air. So if there's like some sort of abnormality, but in front of it, in between or between that abnormality and the probe is just aerated lung, you probably, or you definitely will not be able to get that with the lung ultrasound. So basically, you use that image before to know any sort of normal and a way to identify your abnormal. This is an example of an abnormal. It's a pleural ultrasound actually, but it's an example of an abnormal. Edematous lung or consolidated lung or atelectatic lung looks very different from non-edematous lung, non-atelectatic lung, because these types of lung pathologies tend to have less air in them. They tend to transmit a lot more of the ultrasound waves. And so the parenchyma actually becomes a lot more visible, as you can see here. We're actually going to get back to this example in a little bit. Most lung processes, luckily, that are of interest tend to actually extend out to the periphery. So when we're looking at pulmonary edema or pneumonia or some sort of lesional edema or ARDS, we tend to be able to identify it with the lung or pleural ultrasound. Something that you may not be able to see is like a cyst or some sort of abscess that might be deep to aerated lung. There are certain factors that actually degrade the quality of your ultrasound. I mean, this is true for any ultrasound, but it's really important to remember that for lung ultrasound too. Obesity tends to be an issue just because fat attenuates sound. So especially if you're using like a high frequency probe, that vascular probe, high frequency tends to be attenuated a lot more easily because they don't have as good penetration. And so fat will attenuate those sound waves going in, and so the images that are reflected back just won't be as good of a quality. So you may have to use a lower frequency probe for obese patient. It's the same thing for anyone with a lot of subcutaneous edema. It's just all that edema can attenuate the ultrasound waves that you're transmitting. These two, obesity and subcutaneous edema, can also make visualization of deeper structures more difficult because the farther something is away, the less likely the amount of ultrasound waves that are desired to reach it would reach it, because as it's passing through all that extra tissue or edema or what have you, some of the sound waves are absorbed, some of it is reflected, some of it's scattered. So what actually ends up reaching that deeper structure is less than something that's a little bit more superficial. Subcutaneous air will be a problem too. Just like air in the lungs tend to reflect ultrasound waves, subcutaneous air will also cause that impedance difference. And then rib shadowing can also be an issue because it can cover up abnormalities. Just because there's a lack of ultrasound waves that can penetrate bone, you see this sort of shadow behind it. And this is just an example of rib shadowing that you can see over here. So how to perform a lung ultrasound? Well, there's actually a very standard way of performing a lung ultrasound. In the most ideal situation, your patient is able to sit upright and they're able to move their arms. By convention, the transducer is held in a cephalad position. So that means that probe marker is towards the head, and it would of course correspond with that whatever dot is on your ultrasound screen. With the standard setup, the left side is then cephalad if you're using like the vascular probe with a curvilinear probe. If you are using the phased array probe, just remember that typically on the phased array probe, it'll be in the cardiac setting, and on the cardiac setting, that dot is on the right side of the screen. So then the right side will correspond to the cephalad, but you still hold the probe marker towards the head. You adjust the depth, you adjust the gain, you try to adjust the focal point so you get to where you're at. And then these are just scan lines that you do. Anteriorly, the scan line is along the mid-clavicular line. If you do it if you do scan on the side, it's just mid-axillary. And then if you are able to scan from the back, it's the scan line is just medial to where the scapula is. Just because if you try to scan above the scapula, you just get nothing but shadowing. The problem is that with our population, patients tend to be supine. So of course, most likely we will not be able to scan the posterior thorax, and they're usually not seating or sitting. What you can do is you can try to bump the patient up. So if you're trying to say, you're trying to get identify a left-sided pleural effusion, you can put a blanket underneath the right shoulder and try to just try to make their left side lower than the right side so that gravity can help you a little bit, and same on the other side too. If possible, you can get someone to help you turn, but usually you don't need to do that as much for critically ill patients. But if, say, you were worried about something, then you could have someone turn in the lateral decubitus position. So with the transducer, you hold it like a wand, you apply firm, steady pressure, and especially if they have a lot of soft tissue, you really want to make sure you're really holding pressure to compress down the tissue so that it can transduce or transmit those ultrasound waves better. You slide the transducer from interspace to interspace as you go up and down a scan line, and you try to do it in an orderly fashion based on where the lobes are. So on a supine patient, you could do it in all 6 lobes, or rather all 5 lobes plus the lingula, and you just try to do it the same way each way. There's no exact, there's no real identified way of doing it. Usually I just go, whichever side my closest on, I go from top, bottom, and then go to the other side, top, bottom. Sometimes it helps if you want to come back to it to just label your images. Yeah, that's it. Bone can, as we said, can block the transmission of ultrasound. So what you may want to do sometimes with that is that if an abnormality is deep to a rib, you can sort of angle under or over the rib. I don't know if this makes sense, but if you take a look at what I'm doing over here with the pen, if let's say this is the rib and this is your ultrasound, you may want to try just pull that skin and soft tissue just underneath and then angle up, or you can go above it and angle down. And that's a way that you can sort of get just below it, as long as you're just directing that ultrasound wave towards whatever you're looking at. It sometimes works, it sometimes doesn't. It's much harder if someone has a lot of soft tissue because you won't be able to get the angle that you want. Solid organs tend to transmit ultrasound waves very well. So when we're doing a pleural ultrasound, it's very good to try to identify the solid organs that are there. This example is over here is just one of my ICU patients who was developing pretty bad pleural effusion throughout the night. But you can see solid organs, atelectatic lung, an effusion of some sort here, and this is all that soft tissue. Okay, so then what are the signs that we look for? So one of the first signs we look for is called lung sliding. What you want to try to do is you want to adjust the transducer to center between 2 ribs. You put the ribs on either side of the screen. So can't see it here, but there's one, you can see one rib here, the shadowing underneath. The pleural line lies about 0.5 to 1 centimeter deep to the origin of the rib shadow. So for this particular ultrasound, this is your pleural line. And I wanted to show you guys what the pleural line looks like on a phased array probe. Okay, and it's right over here. So on a normal exam, the pleural surfaces move against each other during the respiratory cycle. And this causes what you see as lung sliding, that visceral and parietal pleura just rubbing up against each other. They tend to move in synchrony with the respiratory cycle. And so that's sort of one way you can confirm that it is lung sliding. And it is a normal finding. You want to see lung sliding because it is a sign that you probably have normal lungs over there. You can also see something called a lung pulse. A lung pulse is when the pleural line moves in sync with cardiac pulsation. And it's because that force of cardiac pulsation, for some people, is sufficient to move the overlying lung and the visceral pleura. And so sometimes you see that little lung pulse, and you can see it best on the left side, just because of the proximity to the heart. Other examples of lung sliding, Oh, this is blank, okay. Another linear probe lung sliding over here. You can see that little shimmering along, and then some lung sliding over here. You're really looking for that pleural line. You can see that shimmering, and that shimmering is lung sliding. So as you can see, the pleural line just looks a little bit more sharp, and it's a little bit more obvious which one's the pleural line on the vascular probe, just because the resolution is better with the high frequency, versus the phase array probe, low frequency. You can see it clear. You can see it relatively clear here, but you can see that it's just much more grainy, just not as good of a picture. So that's what I mean, that when you can use a phase array probe to do all sorts of the lung ultrasound, but your picture sometimes may not come out as well, and so you may have to switch over to a linear probe if you really want to look for that lung ultrasound. Lung ultrasound finding of lung sliding. All right, so if you are having trouble looking at lung sliding, you can actually use M mode to help you. M mode is just a way to increase your temporal resolution. Because the nice thing about M mode is that you're only looking for all the brightness patterns across this one line, right where the cursor is. So what it is I'm gonna put my cursor along some part of the ultrasound, and then it's gonna basically graph it out as a function of time. So on the x-axis you have time, and the y-axis you have that change in the brightness over that amount of time. And so you graph it out, or you lay it out sort of like this. And if you're looking for lung sliding, you just put the cursor over your pleural line, and you hit M mode, and then you get something like this. This is called a sandy beach sign, or the seashore sign. It gives you a better visualization of lung sliding, because lung sliding is something that's moving. So it's easier to do it when you have better temporal resolution. It's called a sandy beach sign or seashore sign because it kind of looks like a seashore. You have this sort of border right here that's a pleural line, and this is really what you're looking for, that shimmering over there, and that seems to be the border between, say, the ocean and then a sandy beach. Other examples of the seashore sign. This image probably could have been better. We could have decreased the depth a little bit, but this is your pleural line. You see that shimmering is seen over there on M mode, and that looks like a sandy beach, but you're really looking at that pleural line over there. And then this is for the curvy linear probe, and then this is another example for the vascular probe. Right, that pleural line right over here. And you can see that shimmering that gets translated onto M mode. So what's the significance of lung sliding? Well, if you see lung sliding, it effectively rules out a pneumothorax. This was seen on a chest paper in 1995 by Lichtenstein, who basically found that the sensitivity and specificity of lung sliding to rule out a pneumothorax was 95 and 91% respectively, and there's a negative predictive value of 100%. Since air tends to float, you usually want to ultrasound in the anterior compartments of the lung ultrasound, and assuming that it's an uncomplicated pneumothorax, like there's no loculations, or it's not traps anywhere, or it's not a mediastinal pneumothorax, you will see a lack of lung sliding if there is a pneumothorax. So our critically ill patient is actually perfectly positioned for this exam, because you really just want to get the anterior portions, because theoretically that's where the lung is floating to. However, one thing that you really have to keep in mind is that if there's an absence of lung sliding, if there is no lung sliding, it's not as useful. The loss of lung sliding, yes, can occur when there's a pneumothorax, but there are so many other things that it can occur with. It can occur because there's a pneumonia. It can occur because there's a bronchial obstruction. It can occur because there's a pleural pathology. It can occur because someone right main stem. It can even occur if someone was just being apneic and not breathing. Because all lung sliding tells you is that there is no, the visceral pleura and the parietal pleura are not rubbing together. So of course we see that in a pneumothorax because there's an obvious separation of the viscera and parietal pleura. But there are also other pathologies where the viscera and parietal pleura are not separated, but they're just not rubbing against each other. Say like an inflammation, or if that part of the lung is just not being aerated at all. You may see a lung pulse if that was the case, and this at least tells you that there is there is the viscera and parietal pleura are next to each other, and it may not be the respiratory cycle that's causing them to rub against each other, but the cardiac oscillations can cause it to rub against each other. One example would be like if you main-stemmed if you right main-stemmed on intubation and you try to do a lung ultrasound on the left side, and as you're sort of bagging the patient, you're only ventilating the right side. The left side is not seeing any ventilation, so you're not going to see any lung sliding relative to the respiratory changes or respiratory movement. But let's say you move the ultrasound probe down by the lingula where it can actually see some cardiac oscillations, you may actually see some lung sliding because the viscera and parietal pleura never actually separated. You just didn't see any lung sliding because it was not being aerated, or that part of the lung was not being aerated. All right, so here's some examples of a lack of lung sliding. Again, this probably could have been better. We could have reduced the depth a little bit, but here you can see your pleural line over here. It's not really moving. And just concentrate on like the first half of this image, because this movement right here, this movement is just movement of the probe. But if you look right here, there's just no shimmering, okay? Another example on a phased array probe, this is your pleural line. We know it's a pleural line because this is a big B line, and we're going to talk about B lines in a few minutes, but B lines tend to follow the pleural line. And so that B line is not moving. And so this is an example of a lack of lung sliding. So what would happen if we end-moded the lack of lung sliding? Well, you would see something called the stratosphere sign, where you just see these straight lines and no evidence of shimmering at all. And so this image was actually twofold. This was on my own lungs where I held my breath and then I took a breath right around this point. And it's not perfect because I think I was moving the probe a little bit, but you can see that the lines are just very straight as compared to over here when I started breathing again. There's a little bit more static kind of feel. That shimmering is being translated. And so when I was apneic, that pleural line was just absolutely straight. There was no apposition of the visceral and parietal pleura. And then once I started breathing again, there was opposition of the visceral and parietal pleura. And so this again is called the stratosphere sign, right over here in that first 2/3 of the image. And we call it the stratosphere sign because it looks like lines in the atmosphere because there are no broken lines due to a lack of lung sliding. Okay, another sign that you may see, and this is one you would see on that would be very good evidence for pneumothorax, is called a lung point. So sometimes, with pneumothoraces, you can have a complete pneumothorax where just all that extra pleural air just completely surrounds the lungs. But based on your your time in the ICU, you've seen that not all pneumothoraces are the same. Certainly, some are smaller than others. And when you have a partial collapse of the lung, where you have part of the lung that's still opposed to the chest and part of it that is not, then you can still have some expansion of part of the lung. Then the part of the lung that is still being expanded, that is the part where you can see lung sliding. And then the part of the lung that is not opposed to the chest wall, that is the part where you can't find any lung sliding at all. And so if you look right at that point, it's called a lung point. And it just tells you that there's a partial collapse of the lung, which means that there is definitively a pneumothorax over there. So this is just a very good example of a lung point over here. So this part of the lung, you can see it's shimmering and it's going back and forth because as the patient breathes in, that it just expands out that lung. And it causes the apposition of the visceral and parietal pleura. And then we can see over here, this part of the lung, this pleural line, there is just no movement because that part of the lung or that part of the parietal pleura is not seeing the visceral pleura at all. Okay, another example of lung point, just very quickly, you can see that there's some movement over here, but no movement over here. Just an example in a phased array probe. Again, just not the best in terms of quality, so it would be much easier to see it in a vascular probe. Okay, so this sign is 100% specific for a pneumothorax, meaning if you see it, there's definitely a pneumothorax. But it's relatively insensitive. just because you don't see it doesn't necessarily rule out a pneumothorax. And it can be very hard to find a lung point. It tends to be a much more senior kind of move where you tend to need a little bit more experience in order to find it. So it's something to keep in mind. Wouldn't expect to always find it though. Okay, other characteristics of lung ultrasounds. So we have something called A-lines. So with standard technique, you can see these air artifacts that we call A-lines. These are one or more horizontally oriented lines that are deep to the pleural line. These are actually a result of a reverberation artifact, and they always occur in the presence of air. So that's how you can remember A is air. And so what's happening is that the ultrasound will send out its ultrasound waves, and at that pleura-lung interface, there's a change in impedance, and so some ultrasound wave will go through, yes, some will get scattered, some will get absorbed, yes, but some of it will be reflected. And so that first reflection is what the ultrasound probe and machine puts together as a pleural line. However, that skin and probe interface also has a big change in impedance, and that can reflect back sound waves. And so that gets reflected back down, and when it sees that pleural lung interface again, it can get reflected back up. And so because the ultrasound works by time, it thinks that this particular ultrasound just took 2 times as long to come back, which it did. It technically took 2 times as long. But what it's going to think is that because it took 2 times as long to come back, it's 2 times as far away. That's how the machine is going to put it together. And so you're going to see a line that's equidistant from the ultrasound probe to the pleural line, that same distance below the pleural line. And it's going to get a slightly weaker line here, and that's your first A line. This can get reflected again, reflected back, and that's another A line over here. And so these first, second generation waves are, the ultrasound just thinks that the ultrasound waves are coming from deeper than they really are due to this sort of reverberation. The waves are therefore always multiplicative of the distance between the skin and the pleura, okay? So when you see A lines with lung sliding, that indicates normal aerated lungs. So that's what you want to see on like on people when you expect to find normal lungs, and then anything else is some sort of abnormality. So without lung sliding, the A lines are actually not as useful. So that's why they have to they sort of coincide, because you can still see A lines in a pneumothorax because you still have that air pleura interface. So you can see A lines with a pneumothorax, you can see it in the absence of pneumothorax, so you sort of want to just see them together. So just seeing A lines does not necessarily mean that you have a normal lung. You really want to also see it in the context of some lung sliding too. Okay, some examples of A lines. This is a curvilinear probe. You have your pleural line over here. So the distance from this, the skin, to that pleural line, and then another, and then just equidistant to that, that's your first A line, and then over here you can see that second A line coming into view. These are also A lines too, they're just a little distorted because that's a curvilinear probe. Another example over here, pleural line, first A line, so that the distance between this and this is the same between this and this, between this and this one. Oh, excuse me, I'm sorry. So this is your first and second generation arterial lines, okay? Now, sometimes you'll see something like this, which can be easily mistaken as your actual A lines, and they're not. They are, in a way, A lines. We call them secondary A lines, but they're not the actual A lines that we care about. These probably happen because of another interface, I'd say, between the muscle and the fat that you can see over here. That also leads to a change in impedance. And so if you think about the distance between here and here, here and here, and here and here, that's probably where those secondary A lines are coming from. The ones you really want to focus on are the true A lines coming from the pleural line, or that are reverberations from the pleural line. All right, B lines. So with standard scanning, if you see edematous lungs or consolidated lungs, but usually edematous lungs, you can see this characteristic air artifact that are called B-lines. So the properties of B-lines, they originate from the pleural surface, okay? So they have to come from the pleural surface, okay? So if you take a look over here, you can see that this is a B-line, it's coming, this is your pleura, and this is your A-line over here. Okay. They always extend like a ray down to the bottom of the screen. So they have to take out the entire ultrasound screen. Anything short of that is probably just a comet tail artifact. And comet tail artifacts are pretty non-specific. You can see them in edema, but you can also see them in like calcifications or some sort of abnormality that's just causing sort of slight reverberation within itself. The way that the B-lines are created is that if you think about a thin layer of fluid that's sort of trapped between the pleura and the lung because of that edema, if you imagine that sound wave going into that little area and then just bouncing back and forth really quickly and just not stopping, that is what's forming all those different artifacts. So they're basically like a whole bunch of reverberations just reaching all the way down to the bottom of the screen. Aerated lungs tend to have a few B-lines. So this is actually a normal lung because you see A-line, you see lung sliding, and it's okay to see a few B-lines. But typically we want no more than 3 per screen. And if it's anything more, it tends to point something a little bit more pathologic. B-lines, as I mentioned before, generally move with lung sliding. However, they don't have to be mobile. You can have B-lines without lung sliding, just like we saw in that image before. So this is an example. It's a little hard to tell, unfortunately, because it looks like it's moving, but if you just concentrate right over here, that B-line is just not really moving at all. This is an example of someone who was in congestive heart failure who had a lack of lung sliding because their lungs were just so full of fluid that they were not aerating. And so you can see the pleural line, you can see the B-lines, but the B-lines are sort of stationary. And you can see that there are no A-lines here at all because it was just completely consolidated. Well, not consolidated, edematous. Other properties about B-lines that you should know is that A-lines and B-lines cannot coexist at the same point. So B-lines tend to efface A-lines. So you can see it coming in here. So you see this really clear A-line in the beginning, and then as the B-line comes in, that A-line disappears, and then as that B-line passes, that A-line comes back. And so this is because B-lines are from small amounts of fluid, and A-lines are from aerated lung. And so they just they can coexist on the same image, but they can't coexist at the same point. So B-lines would just efface the A-lines. So just another example of a B-line effacing an A-line over here. You see that if I had a longer image, you could probably see that as it comes in, that A-line goes away. This one was just a little bit clearer than this one. Okay, so B-lines are seen with lung edema, or any process with infiltration of the lung interstitium, so some inflammation, neoplasm, scarring. It's just thought to be ring-down artifacts from small subpleural fluid collections. The presence of B-lines has been strongly correlated with alveolar or an interstitial pattern abnormality that has been seen on CT scan. The presence of B-lines also rules out a pneumothorax, just because if you think about it, this makes sense, because if you had a pneumothorax, you would have this air interface that would separate out the lung from the chest wall, where you wouldn't be able to see the pleura very well at all. And so if you can see a B-line, you probably don't have a pneumothorax, with or without lung sliding. And it's just because if you had pneumothorax, the lung ultrasound wouldn't be able to travel very well through the air, so you probably wouldn't be able to see what's deep to the air pocket, which is that pneumothorax, so you probably wouldn't see any B-lines. So depending on the pathophysiology, you can see a lot of A-lines, normal lung or even some abnormal lungs, or you can see a lot of B-lines. You can also see them located diffusely, you can also see them located very locally or focally. And so we image the entire lungs in order to sort of get that pattern. This example over here is just an example of a lung with a lot of B lines. You can see that there's so many of them that they're starting to coalesce. And so this was a very edematous lung. Consolidation or consolidated lung tends to also look very different. As we had mentioned before, consolidated lung tends to be very less aerated, and so it almost starts to look like a solid organ. Like it can look very much like a liver or a spleen. And for that reason, we call this the hepatization of the lung. And so if you look at this image, if you pretend that there were no markings here, it would be hard to tell which one was a solid organ and which one was a lung. Oh, sorry, which one was the solid organ, which one is the lung. You usually need to sort of look at what's going on. Consolidated lung tends to have some air bronchograms, and it's just because there's an edema around the bronchus that becomes very echogenic, even with a small amount of air in them. However, these air bronchograms can look very much like vessels, so that's not as helpful. Often you need these anatomical markers to sort of show you what's going on. So for this image, we have a curvilinear probe. You have all this soft tissue, some muscle, and you have two things that can look like solid organs. It's a very clear difference between them. And so this is a pleural ultrasound, which we'll get to in a few minutes. But based on the way it's domed, this has to be the diaphragm, that white line. And so what's below the diaphragm is your solid organ. In this case, it's the liver. And so above it is your lung. And so this is consolidated lung with those air bronchograms that you can see over here. And then there's just a little bit of pleural fluid that's sitting outside of that consolidated lung. Now, finding consolidation on a lung ultrasound is purely descriptive. It doesn't actually say what's causing consolidation. So it could be pneumonia, it could be CHF, it could be atelectasis. So it's just a descriptive property that you find, and then it's up to you to correlate it clinically. So it's up to you to find the cause. Are there any questions so far about lung ultrasound before I move on? Okay. So for the next part, we're going to do some pleural ultrasound. Sorry, 1 second. Okay. So for pleural ultrasound, the probe type that you will need is one that will allow depth. So the preferred one to use is actually the phased array probe. You can certainly use the curvilinear probe if that's what you have in hand. And both will allow you the depth penetration that you need. The good thing about the phased array probe is that the footprint is smaller, so you can fit it in between two ribs, whereas, sorry, my internet connection is unstable. Okay, whereas with the curvilinear probe, you have a big footprint, so you may get a lot of rib shadowing artifacts in your image. When you're scanning, the first thing we saw was the superficial approach to look for lung sliding. Now you can what you're going to do is you're going to bring the probes out to the side where the costodiaphragmatic angles are, and look at the pleura. And certainly you were looking at the pleura before too, but that was more considered what we say lung sliding, and this is your actual pleural ultrasound. All sort of builds into the whole of lung ultrasound itself. Pleural fluid tends to be gravity dependent, so the recesses are often the best place to look. So this is why we usually want patients sitting or at least bumped up, so you can use gravity to help you look for that fluid so that it's not spread around when they're supine. Again, the orientation of the probe, the image marker on the screen tends to be on the upper left corner unless you were using a phased array probe on the cardiac setting. If you were on a phased array probe, you can, the more modern ultrasounds now, you can change the setting so that it's an abdominal approach or another type of approach so that the probe marker is on the left side. You should orient the probe marker on the ultrasound probe itself, cephalad if possible. So on a normal exam, you just, again, you place the rib on an interspace, longitudinally scanning. These pleural lines will be as bright lines on the surface, and you just sort of scan longitudinally, meaning up and down, to look at adjacent spaces. a lot of times what helps is just trying to identify that solid organ first, and then just moving up a rib space until you can see the diaphragm, which you can see here. So this is an example of liver. This is that chest wall that you can see here. This is the diaphragm. The diaphragm is, we know, is domed down with it wrapping around that liver. So you know that, that's how you know that this is definitely the solid organ. This is the diaphragm, and then what's above it is the lung. Okay, mediastinal pleuris tends to not be very visible, so I wouldn't focus on that at all. The pleural thickness tends to be about 0.2 to 0.4 millimeters thick. Just something to keep in mind when we're looking for inflammation, because on inflammatory processes, the pleural line tends to be a little more thickened. Yeah, all right, so, oops. So pleural effusions are usually what we try to look for with pleural ultrasound. Now, they're a very common occurrence in the ICU patient. Most common causes, CHF, atelectasis, parapneumatic effusions, hepatic hydrothorax are examples. Use of the ultrasound can be really helpful, especially if because the fluid is less echogenic than soft tissue. So fluid, especially if it's simple fluid, tends to be basically hypoechoic, meaning that they don't, or rather they just sort of come out as black on the screen. You can see effusions as small as 3 to 5 millimeters versus like a chest x-ray. You usually, to see a pleural ultrasound in chest x-ray, requires 150 cc's of fluid for that effusion. And ultrasound, you need about 5 cc's to identify a pleural on a pleural ultrasound. It's definitely superior to x-rays in detecting a presence of pleural effusions, especially in outpatient population, because they tend to be supine. You know, supine patients, when you look at a chest x-ray, that pleural effusion may be a little bit more layered, and so sometimes it looks more like a consolidation in the lower lobes versus a pleural effusion, whereas if you stick an ultrasound probe on someone, you can clearly see that fluid space that's separating out the pleural wall, the diaphragmatic wall, from the lung itself. So what do you want to identify? You always want to identify the anatomic boundaries. So you want your solid organs and your diaphragm on one side, your likely atelectatic or consolidated lung. Structures deep to the pleural space may be difficult to find. Over here, you're actually seeing some debris that's down there. If the patient was really thick, you may not see anything below, just because it may reach too far. If they're very thin, you may see a vertebra, but they would have to be pretty small. And then this is your chest wall over here. You want to look at any hypoechoic spaces. You really want to identify that hypoechoic free space, which denotes your pleural effusion. And then you also want to look for any dynamic changes that are associated with pleural effusion. So any respirophasic or cardiophasic movements of an atelectatic lung, or changes in the size of the pleural effusion based on the expansion of the lung. And so you want to look for those changes in order to help identify your pleural ultrasound. So your pleural effusion on your pleural ultrasound. This is an example of a simple pleural effusion. So just to identify, this is your solid organ over here, right? And this is the diaphragm moving up and down with each respiratory cycle. Your diaphragm was over here, your chest wall, structures as deep to it. I think this could almost be, it looks like there's some shadowing there, probably be some ribs or something. And so we don't see any atelectatic lung because they're probably in the, this effusion is so large that you would have to go up a rib space if you wanted to see that atelectatic lung. But if you went up a rib space, you would probably lose the solid organs over here. So we can probably consider this a pretty large pleural effusion. This is an example of pleural effusion with atelectatic lung that you can see. Notice that you see the lung floating in the fluid. There's slight movement towards the diaphragm with inspiration. Just sort of inspire. And then you right at the end, just when the patient's exhaling, you can sort of see it collapse a little bit. Unfortunately, the clip is just not long enough to show the full respirophasic changes to the lung. Note the hepatization of the lung, right? This atelectatic lung looks very liver-like. This is probably just some consolidated air bronchogram over here. And then notice the flapping of that collapsed lung. This is actually called a jellyfish sign. If you just see a little bit of lung sort of flapping in the wind over there, it's a sign of an atelectatic lung. So that's a jellyfish sign. This is a dynamic picture of a simple pleural effusion with a compressed lung. It comes into the atelectatic lung comes into the picture as a very echogenic material towards the end of the clip. So if you just wait until the end of the clip right here is just as that lung expands, because it is atelectatic, but as you breathe, some parts of it will expand. It's coming into view of this probe that's not moving. And so that is atelectatic lung that's expanding. And that's an example of a respiratophasic change. This is an example of looking at the pleural effusion from the parasternal long axis. Note that the fluid that you look for over here, you know that this is a pleural effusion, this fluid, because it is below the descending aorta. And so how do I know this? Well, I know that the pericardium wraps around the heart and then sort of wraps up here above the image of that thoracic descending aorta and sort of curves out over here. And so when I look at this picture, the question I will have is this a pericardial effusion or a pleural effusion? Well, if this is a pericardial effusion, I will be sitting in the pericardium. And if I know where the pericardium is, it's up here along this line. That would mean that any pericardial effusion that occurs has to be above the descending aorta. And so because this effusion is happening below the pericardium, below the descending thoracic aorta, this has to be a pleural effusion. And this is probably some atelectatic lung that's sort of coming into view. Assessing the size, there have been a few studies that looked at gauging the size of ultrasound versus, say, another type of radiographic way of doing it. The study in 1994 did find that the ultrasound method was better. The study in 2005 tried to classify effusions as above 500 cc's or less than 500 cc's based on what they saw on the lung ultrasound, and then they drained it to see if they were correct. And they found that sonographers can accurately predict effusions that are above 500 cc, so they can predict large effusions. It's really when it's small or moderate that becomes a problem. And this other study in 2006 tried to come up with a formula of how to quantify how much pleural effusion you have based on your distance. So you could use this. It's not the hardest equation. You just look at your max distance from your pleura at end expiration. So between the parietal and the visceral pleura, you probably try to look for the biggest line. The question will be like that. I always have a problem with this: is are you scanning at the right place? If you have a big pleural effusion and sort of an uneven line, where do you look for it? It just sort of becomes a mess. And we know really clinically, if we think about what we do in the ICU or in the OR, the questions that we are asking really is, can we tap it or can we not tap it, right? Is it big enough to tap, or is it just not something that we would tap? Is it loculated, or is it simple, right? Would tapping it cause problems? Where is this located? Where can I find this effusion? Is it small, medium, or large? So knowing the exact size, probably clinically not as helpful, but knowing it's just sort of a relative gauge of how big it is and whether you would tap it or not is probably the most helpful thing. So how do we characterize the fluids? Well, transudates are often anechoic, and so they don't tend to have any echogenic material. And so these are deemed simple effusion. So if you see only a hypoechoic space, nothing else, then it's a simple effusion. However, exudates tend to have some sort of echogenic swirling pattern or some sort of echogenic material in them. You can see debris, you can see these fibrin strands, you can see septations. It was like a loculation. So this is an example of a complex pleural effusion. You can see that instead of just a simple fluid, you can see some echogenic material within. So flapping there in the fluid itself. This was just fibrinous material that's seen on the diaphragmatic pleura. that's opposed to the atelectatic lung. So there's probably some inflammation going on here that's causing this. Other examples of complicated effusions. So you can see this image over here. You can see a lot of fibrinous material. You can see some septations. You can see loculations over here. And so right over here is probably your consolidated lung. And then down over here, or up over here rather, is yet complex pleural effusion because of all those deposits and loculations and septations. Right? When you see a highly cellular exudate, it usually points towards an empyema or hemothorax. So there's just two things in the differential to keep in mind, because where else can the cells be coming from? And then if you see septations or stranding, it tends to be suggestive of parapneumonic effusions or empyema. So we have another sign to look at. This is called a plankton sign. And unfortunately, I could not find any patients, or my patients anyway, that exhibit it. So I'm going to have to use YouTube to help me out. So this is an example of a plankton sign over here. So as you can see, there's this like a little bit of debris over there that's sort of floating and moving around in the pleural effusion. Just to show you again. Oh, it's not. Sorry, 1 second. My computer's being very slow because I have all these programs open. Okay, anyway. All right, so this is what we call the plankton sign. This is another example of complex effusion. These are just cellular exudates. These are just debris that's being agitated by either cardiac or respiratory motion in that pleural effusion. Now, if you were to see this debris collect, and there was a clear difference in the echogenicity of the effusion and then what the collection is, we call this the hematocrit sign. And so this is an example of hematocrit sign, where you see this change in how it looks, that effusion, where this is sort of still semi-liquid over here, but there's a change in that collection over there. We call this hematocrit signs because you usually see it in bleeding. And in fact, this patient was actually developing a really bad hemothorax throughout the night that I was following. And you see that it was a clear hematocrit sign. And it happened because they placed a chest tube into one of the vessels. So just an example over here. Once you characterize the effusion and the size or the relative assessment of it, the question would be, are you going to tap it, right? Is this affecting the patient clinically enough for you to want to tap it? Can you even tap it? Would you be able to reach it safely with a needle? Are there any problems with tapping it? Is it loculated? Do you need to put it in a chest tube, or would a thoracentesis be okay? Usually you want to do this over multiple respiratory cycles. You want to avoid major organs. You can do a diagnostic or a therapeutic thoracentesis. The way to do a thoracentesis is out of scope for this lecture itself, but really the pleural ultrasound is what's guiding you to help find a good pocket. You can actually use this for real-time guidance of the needle, just like we would, maybe do a block. You can just watch that needle go into the pleural space. You can actually have real-time visualization of that pleural effusion being drained out. And for those of you who've done a thoracentesis before, you'll know that sometimes when you put a catheter in there and you're draining, sometimes it'll just stop draining, even though you're pretty sure you still have fluid in there. So you can actually use the ultrasound to just sort of see what's going on. Is it just like kinked? Is it hubbed up against maybe some re-expanded lung, or has it just migrated somewhere, or you picked up some sort of debris? Any questions so far before I move on to the next part of our ultrasound lecture? Okay. So our lower extremity venous exam. So I think it's helpful to learn how to do a very focused DVT exam. I am not advocating that anyone becomes like an ultrasound tech and does whatever they do. They do this whole long ultrasound where they do Dopplers and color and they do multiple vessels.
Can I ask a question?
Oh yeah, sure.
Just like kind of a general thing for lung exams, would you reach for the vascular probe or the cardiac probe first
So
when
very
you
good questions.
the probe?
I like to do I like to do the full comprehensive exam, and usually I'm in a hurry, and so I actually like to do it with a phased array probe first, and I will only switch to the linear probe if I'm having trouble seeing lung sliding, which happens more often than not. So I usually start with the phased array probe because I switch back and forth between the lung ultrasound and then my cardiac ultrasound. And then if I really need to feel like I need to clarify and be absolutely sure that there is lung sliding or not lung sliding, then I'll switch over to a vascular probe.
Thanks.
Anything else? Okay. Okay, so our focused DVT exam. Oh, yeah.
Sorry, this is Leah. I just texted in a message. I was just wondering, what depth do you usually set your transducer to?
It varies based on patient, based on how much tissue they have. But oh, sorry, 1 second. Let me go back.
Like 10 centimeters. But if I typically have I'm just more comfortable with a flat probe. Would I be wanting to get it that deep?
Well, the problem with the flat probe is that you can probably get it that deep, but you'll see that the images just become terrible, which is why we don't typically use it.
Okay, all right.
So like, let's say I'm using the flat probe for my lung sliding ultrasound, right? So I typically would probably go like maybe 5 centimeters because that's how far down it will go. The more depth you have, the worse your axial and longitudinal resolution.
Yes, absolutely. I guess maybe I should be more specific with my question. If I'm using a flat probe, looking for pneumothorax, I would expect to have good detection of lung sliding at a very shallow level. Do I need to worry about being able to see A lines for many repetitions and B lines?
Oh, no. You really only need to see like the first generation. Sometimes it helps to see even the second generation, but you'll find that as my examples have shown you, even if you go further down, they just tend to be obliterated. So once you see a first generation A line, it should tell you enough that there is aerated lung.
Great, thank you.
Okay, so lower extremity venous exam. So the nice thing about this is that we definitely use the linear vascular probe for this. I mean, you could theoretically use the phased array probe. I've tried it before. It makes everything a little bit harder to see. I mean, you could theoretically see it. It's just much more grainy. So because we're looking for vessels, we used our vascular probe, high frequency probe. So what the use of the focused DVT exam is that if you have someone in some sort of respiratory distress and you suspect that it's PE because you sort of ruled everything else out, you can sort of look for a DVT to help you or help guide you to that diagnosis. Now, that being said, a lack of DVT does not necessarily rule out a PE. It's just that if you do see a DVT and you do have someone in respiratory distress, it just adds sort of another thing to your clinical exam and your questions that you can be highly suspicious, and it could be strongly suggestive that someone has a PE. Okay. So the best way to do this is just to position them in the frog leg position, sort of like how when the nurse is putting in a Foley for a female patient, they put the feet together. Well, the bottom side of the foot, what do you call that? The bottom side of the foot, the soles of the foot together, so that you can sort of get the legs sort of in a more open position. And then you straighten out your vessels. You are only going to look at major vessels in the focused DVT exam. So you're going to skip the calf vessels. You're not going to look. Sorry, my internet connection is unstable. 1 second. You're not going to look at the iliacs. Like, these are the things that like the ultrasound tech would be. You're going to do a very cursory exam just to sort of give you an idea of whether you need to do more investigation or whether it's something that's very clear that you can see a clot. Okay. You're going to look at all the vessels in the axial view. You can do longitudinal if you wanted to, especially if you see a clot and you just want to clarify it a little bit more. And then you got to compress each vein to look for a clot. And the reason why we have to compress is because acute clot can be very gelatinous, and it may not always actually be echogenic. So you may actually be looking at a vessel that has a very acute gelatinous clot, which may be completely missed. But once you compress it, you'll see that it can't compress all the way. And that's one way you know that there's a clot there. Of course, if there's a very obvious clot, like it's a clot that has organized and developed sort of a shell, then you don't need to compress it, because if you do compress it, you risk sending the clot off. Okay? So this is just your first example. So the first place we're going to put the probe is where the common femoral artery and vein are. So image on the left over here, just your normal size vessels, your vein, your artery, and then I'm going to compress all the way down. And you see that it compresses, there's no clot over there. So the next thing I'm going to do is I'm going to just keep the probe on the patient's thigh, and I'm just going to slide distally. And so that my next image that I look for is now right where the saphenous vein takes off from the common femoral vein. So you'll notice that the superficial femoral artery and the deep femoral artery, also known as the profundus, has already split. So, you know, this is a DVT exam, so I don't really care about the arteries, but they just act as sort of anatomical landmarkers. But this is where the saphenous vein takes off. The reason why we care about this part is because the saphenous vein is the only superficial vein that has a direct connection into these large vessels. So if you have a DVT in your saphenous vein, it can travel and become a PE. The other reason why we look over here is because anytime you have a connection of these vessels, this can lead to turbulent flow right over here. And so clot tends to actually develop around these areas if they were to develop. Yeah. So I'm going to, basically I didn't add the image, but you get the idea. I'm going to compress it down, make sure that the saphenous, and this is still the common femoral vein, compress all the way down. If that compresses all the way down, I'm going to keep moving down distally. And now, this is your SFA, this is your profundus, so it's still split. This is still your common femoral vein, but now you start seeing deep perforators. So these deep perforators will now go into the more superficial veins, so they're veins that I don't care about as much because a DVT is probably, or a superficial venous clot is probably not going to be clinically significant. But because you can have turbulent flow around this area, clot can also develop around here. And again, I just compress all the way down. So the common femoral vessel of the vein still has not split yet, but you can see the deep perforator running between the two arteries. Now, as I move distally, now the common femoral vein has split, and I apologize, this particular person just had really weird anatomy. This is my superficial femoral artery. This is my profundus or deep femoral vein artery. This is my superficial femoral vein, and this is my deep femoral vein. Okay, so it has split. So if I were to compress, I would see that hopefully that this and this, the superficial and deep femoral veins, they both compress, but the arteries would not. And again, we look over here because right where it splits, you can have a high incidence of DVTs occurring because of that turbulent flow. Okay, now as we go further down on the thigh, you'll notice that the veins tend to get smaller and they tend to dive down. So we sort of stop at this point, and then we go to the next big vessels, which is the popliteal vessel. And so for this, now you want this patient to be supine with the knee slightly bent, just like you would do if you were doing a pop fossa block. The popliteal vein is the one that's closest to the skin. As evidence here, as I compress the popliteal vein, it compresses all the way. And so there is no clot here. At this point, this will just sort of split into calf vessels. We don't typically, you could if you wanted to, but we typically don't tend to look at the calf vessels just for the focused DVT exam to look for any sort of DVT. So just as a reminder, this focused DVT exam is best used if you are suspecting that clinically there's a PE, and whether or not there is an actual DVT should not help you rule out a PE. Just if there is one, it could be very strongly suggestive of a PE because that person obviously has clot. If there isn't one, they could still have a PE. It could mean that the clot moved or you're just not scanning in the right place. So it doesn't take away from needing a true lower extremity non-invasive exam if you needed one. This is just something you could do in like a few minutes to very quickly scan down the leg to just see if you see something. Some adjunct exam images. This just happens to be a TEE image of a Saddawi-embolus, one of my patients in the Heart Center ICU. I couldn't find one with a TTE, but you can get a very analogous image if you do a parasternal short axis view of the heart, and you just sort of tilt the probe up. And so you can find the spot where the PA splits into the right and left pulmonary artery. And that is just an adjunct image you can get if you're suspecting like a large Saddawi-embolus or some sort of PE. Another adjunct image, TTEs or with the IVC. So this is just looking at the IVC over here. You can see the liver, you can see the RAs coming in and out of view, and this is your IVC right around the area where the hepatic veins will drain into it. We try to get measurements about 1 to 2 centimeters from where that RA-IVC junction is. And so usually it helps to do it in M mode because, again, tends to be a moving structure, so you can get better temporal resolution on M mode. And this is just an adjunctive image, not necessarily useful for lung ultrasound, mainly probably more helpful for heart ultrasound. But let's say you were worried about PE, you may see like a distended IVC, or if you're worried that someone was in really bad volume overload, and you just want to look to see what their help sort of get to at least an idea of what their volume status might be, that might help you gauge what else you're seeing on that lung ultrasound. If you see like a lot of B lines and then their IVC is very distended and they have no problems with their RV, could probably mean that they're in just heart failure. So what do we apply it for? So you can use lung ultrasound to help clarify an ambiguous chest X-ray. The chest X-ray will give you a 2D picture of a 3D structure. So if you see like an undifferentiated lesion or some sort of non-specific radiodensity and you're just not sure what's going on, you can just look at an ultrasound. You can look at the individual lobes. You can help differentiate between aerated lung versus non-aerated lung. You can look at effusion. You can look at for consolidation. And so it just gives you another modality to help clarify what you're seeing. It can be very useful to help evaluate for a pneumothorax. If there is a pneumothorax. So it can be very effective if there is a pneumothorax, just because like when the patient is supine, a small pneumothorax can be easily missed by a chest X-ray because of how the lung, because of how the air travels based on gravity. And so you can see these smaller pneumothoraces or just confirm a pneumothorax if you're worried about one with a quick lung ultrasound. These can be great for emergent situations when it can be difficult to obtain a chest X-ray. I mean, we're very lucky here at MGH the radiology techs come for chest X-rays relatively quickly, but I came from a fellowship where a chest X-ray can take 2-3 hours, even if you put it in stat. So it really depends on where you are. You can use it for post-procedural, looking for post-procedural pneumothorax. So if you were doing a central line or a block and you were worried about causing a pneumothorax, you can lung ultrasound before and after. And if there is a new absence of lung siding, the most likely diagnosis is a new pneumothorax. if you see continued lung sliding, if you had seen lung sliding before and then you see it after, then it effectively rules out a pneumothorax. So the way you can evaluate or use lung ultrasound to evaluate for acute respiratory failure has been broken down in a number of ways. The way I like it to do it is with a blue protocol. It was developed by Lichtenstein, who, as you may have seen throughout the article, has done a number of articles on lung ultrasound. So one of the first things you do is you look for lung sliding. Is it absent or is it present? Okay, so that's your first question. So the next thing you would do after that, whether it's absent or present, you look for what kind of profile do you have. So when we talk about A profiles, B profiles, mixed profiles, C profiles, you're sort of it's sort of telling you what are you seeing most of. So when you go through all the 6 spots to look at all the different parts of your lobes, what are you mostly seeing? So are you seeing, like, say, an A profile, meaning that you see a lot of A lines and that's what you're seeing? So if you see a lot of A lines, then you sort of go down the differential, right? So if you see a lot of A lines, you see irritated lungs. So you can probably say that there's no, you can probably rule out pneumonia, you can probably rule out CHF. Oh, sorry, not pneumonia. You can probably rule out CHF or ARDS rather, because the lungs will probably not be irritated if there's a lot of interstitial edema. So, you know, this is done in the context of someone having respiratory distress. So then what you can look for next is you can do a quick DVT exam. So if they have a thrombosed vein, this most likely points towards PE, and then you would just follow it with other studies to confirm. If there are free veins, it could still be a PE, but then you would do something called maybe a P-lapse point. And the P-lapse point is just your posterior lateral point that you just lung ultrasound. And the reason why we do that is because consolidations, inflammations, they tend to go into the dependent area. So you want to look posteriorly and laterally. And so if you see a positive P-lapse point, meaning that you see evidence of inflammation or consolidation, it probably points towards pneumonia. And if you don't see any evidence of that on both sides, this could be, let's say, like a COP or asthmatic exacerbation. Now, is this like 100% guaranteed? No, this sort of just gives you an idea of how you would sort of think through things and sort of what you would do first. The way I like to do it is I don't like try to figure things out first. I just get all the information and then I break it down afterwards. So I get all my lung ultrasounds and then I ask myself, did I see lung sliding everywhere? Yes. If I did I see mainly B lines? If I saw mainly B lines, it could be pulmonary edema, it could be ARDS. And then I correlated clinically. Does this make sense with what the clinical picture is, with what my other imaging modality is, if I got any? If I didn't see lung slidings and I saw mainly A lines with that. So remember what I said with lack of lung sliding doesn't really help you that much because there's so many things that can cause lack of lung sliding. So you look for other clues. If you see an A profile, it probably could point towards a pneumothorax, but you can't be 100% sure. So you try to look for a lung point. If you have a lung point, you're definitely having pneumothorax. But if you don't have a lung point and you have an A profile, but you don't see lung sliding and they're respiratory distress, not sure. It doesn't really help you that much. You have to go somewhere else in order to look for another problem. And so this A and B could mean that you see a mix of A profiles and B profiles, meaning some lobes you see A profiles, some lobes you see B profiles. That could be like multilobar pneumonia. And a C profile is just a very specific type of property that you see in the pleural lines. And I have an example right over here. So you see this thickened pleural line, and I mentioned before that a pleural line is normally around 0.2 to 0.4 millimeters thick. So if you see like an irregularly shaped pleural line that seems a little bit thickened, that usually is indicative of inflammation. We can see that the lung below here is sort of grayish, staticky, but we don't see any A lines. So it's still aerated, but it still has a lot of fluid. So it's sort of in between that, where it doesn't have A lines, but there's no hepatization, and you don't really see B lines. So this is more of like a C-type profile. So other ways you can apply the lung ultrasound, you can look for it in terms of lung recruitment. So if you see areas of lung that look consolidated or atelectatic or just some sort of gray muddled area, and you do your recruitment and you change your PEEP, if you see it go to mostly A lines in that same spot, it tells you that there is some sort of recruitment. It doesn't tell you whether you're overextended or not, it just tells you whether your PEEP has worked to at least recruit some alveoli. You can help differentiate different types of consolidations. So like, for example, if you have diffuse B lines, it could be really bad ARDS / multilobar pneumonia, or it could be CHF. If you see focal B lines, it's like you only see B lines like in 1 or 2 lobes, that's most likely a pneumonia. If you see it everywhere, it could be ARDS or CHF, and then you will look for you will look at the pleural surface, look for that C type of profile, because inflammatory processes tend to give you a little bit more thickened, irregular pleural lines, whereas cardiogenic edema tends to be associated with a very smooth pleural lining. You can use lung ultrasound to guide your thoracentesis, your biopsies, and then you can use it to help rule out a right mainstem ET tube. How helpful it is, I don't know, just because it's much quicker, obviously, to listen for lung sounds and just pull back by the time it gets you an ultrasound. But that is something that you can use to apply for your lung ultrasound. With the COVID-19, we've been seeing these reports from Italy. What they're seeing is that they're seeing a lot of diffuse B lines, but it's usually bilateral, but they can also see a lot of focal B lines, especially in the dependent areas. And they find that the B lines in the COVID patients are actually very PEEP responsive. So essentially, they look for a response to the PEEP based on titration of PEEP, and they do serial lung ultrasounds to look for the elimination of B lines. The second application that they've been using it for is that they've been noticing, especially what correlates with the CT findings, that a lot of the dependent areas tend to be more consolidated, whereas the anterior areas of the lungs tend to not be as consolidated. So they tend to see more A lines anteriorly and consolidations posteriorly. And so if they actually see that kind of property of the A lines up front and the B lines in the back, it can help them determine whether the patient may be helpful to have them proned. And so that's one way they've been using it too. Obviously, there are a lot of limitations. It requires some special training. You really need to do it a lot in order to get good at looking at the images. Like anything else, you need to see a lot of normals before you get used to the abnormals. But the nice thing about it, again, is it's usually done by bedside. The bad thing about it is that it's done by bedside, so you don't have like a radiologist to scan with you, to show you if you're doing things wrong, or an ultrasonographer to help help you optimize, so you're sort of learning on the spot, especially if you don't have someone more senior to do it with you. They're not good for lesions that are surrounded by aerated lungs, so you may not be able to see everything that you're looking for. And then, of course, there's a lot of machine limitations too. The image quality varies based on what ultrasound probe you're using and what ultrasound machine you're using. As we can see in the main ORs, we may not necessarily have the probe that we want available, so that could be lacking. And then we may or may not be able to save images to help help them be read by someone else, or to help jog your memory for the next day if you're trying to just look at serial imaging. All right, so any questions? I just have like 5 review questions to very quickly do, but if there are any questions, now would be a really good time for them. Ooh. It's almost been an hour and a half. Okay, I'm gonna just very quickly move on to question 1. If anything comes up, you can ask. So question 1, a 52-year-old male with a history of bolus COPD, on HOMO2, coronary disease, insulin and diabetes, comes in with acute shortness of breath. On exam, he's tachypnic, he's tripoding. His ABG shows a PaO2 of 62 on 100% with face mask. You call the x-ray and the machines need to be rebooted, and that's just gonna take them like 15 minutes. You suspect a pneumothorax and you decide to perform a lung ultrasound. What would you expect to see if your suspicion is correct? Oh, you know, I just realized that I first gave this lecture in front of a live audience, and now we're on Zoom. So if you could just unmute yourself and just call out the answer, I won't feel as stupid. Is it A, lung sliding with tremendous amounts of B lines? Is it absence of lung sliding with many B lines? Is it absence of lung sliding with A lines visible? Is it lung sliding with a large DVT in the common femoral vein?
C.
It's what?
C.
Did you
C
say
as in cat.
cat? Yes, cat. Yes, Charlie. Exactly. So yeah. So A will probably be some sort of like a pneumonia or consolidation. B would be if something was really inflammatory, like ARDS. D would be like if you suspected a P, not necessarily pointing to P. So C would be the best answer. Okay. Question 2. Of the following images, which are the most likely to be seen in someone with a pneumothorax?
A.
A, yes, exactly. A, you see a lung point, so that's definite for pneumothorax, or partial pneumothorax. But the second image, you can see very clear lung sliding. I purposely didn't use a very obvious image because I wanted to show you what it looks like in the real world. And then for the third image, because you see B lines, the presence of B lines kind of precludes a pneumothorax. Okay, question 3. A 50-year-old with unknown history comes in with acute respiratory distress. You quickly place an ultrasound probe on him and get the follow images on all lobes of the lungs. What is the most likely diagnosis? So you see this on all the lobes.
C.
Yes. So what are we seeing over here?
Those are B lines.
Yeah, just a lot of B lines, and it's diffuse. So the most likely, out of all of these choices, the most likely would be CHF. And then we'll just make this our last one. A 30-year-old with no past medical history except IV drug use presents with 5 days of fevers, coughs, and chills, now with worsening shortness of breath. His chest x-ray shows a right lower lobe opacity. Place an ultrasound probe in the area, and you see this on imaging. What is the most likely diagnosis?
D.
D. Exactly. And then pyemia. This is a complex pleural effusion. You can see pleural effusion over here with fibrinous deposits, some debris, some loculations, septations. I don't know what the heck's going on over there, but this just a lot of badness going on. All right, and that should be it for today. Any final questions? I'm sorry, I know I took up a lot of time. This was just happens to be a long lecture.
I have to go. Thanks a lot, Mark. I really appreciate it.
Absolutely. Are you like the last one left?
No, there's a few people.
Yeah, I can't see Zoom right now. All right, guys, thank you very much. If you have any questions, you can always email me. I'm just going to stop sharing.
Thank you, Mark.
Oh, sorry, I'm looking at the chat right now. Hold on. Okay, that was Leah's and Max. Okay, so never mind. All right, everyone, have a nice night.
You too. Thank you.